All right, so welcome to hypertension guidelines. Okay, hypertension guidelines, and these are the guidelines that have come out in 2025, in the year 2025. Can't believe it's already been a year, and still these guidelines we call them new. So they're not new, but sort of. They're new for a lot of you folks. Okay, so there are a few things that have changed in these guidelines, and what I'm going to do is, given that a lot of you guys are giving QE1 exam, I'm going to make it into a case-based, question-based format. Okay, all the learning I am going to integrate into a case-based, question-based format. So we are not going to spend too much time about like what is hypertension and why blood pressure occurs and what is angiotensin and what is angiotensin 2 and the pathophysiology. We are not going to spend too much time on it because all these exams, QE1, NEC, etc., they're more worried about what it does to the patient and to the healthcare system as a whole, rather than asking you questions about what is angiotensin or JUN and which hormone changes it to angiotensin and how do calcium channel blockers work. Okay, so we are going to focus on relevant things. Okay, we are going to focus on smart learning. Okay, we are going to focus on smart learning. Okay, so with that being said, let's get started. All right, with our question number one. All right, let's see. So most of you guys think it is D. Some of you guys think it is C. Some say it might be C or D. Let's take a look. So 52-year-old man presents for a routine follow-up. His automated office blood pressure readings over 3 visits are 132 to 136 or 82 to 86. He has no diabetes, chronic kidney disease, or cardiovascular disease. Home blood pressure averages at 128 over 80. What is the most appropriate next step? So everyone, this is your learning number one. Okay, this is your learning number one. So previously, probably 10 years, 20 years ago, the home blood pressure machines were not good. Okay, the home blood pressure machines were not good. So we didn't rely as much on home blood pressure machines. Now they're amazing. Okay. Home blood pressure machines are amazing. So we rely on home blood pressure machines a lot more than office blood pressure readings. Okay. We rely on home blood pressure readings a lot more than office blood pressure readings. So is this person's blood pressure at home normal, everyone? Approximately normal? Yes, no, yes, no? Type in the chat box. Type in the chat box. Yes, no, yes, no? Yes, Samuela says yes. JD's iPhone says yes. Full stop says yes. MS says yes. Absolutely. Yes, correct. So, seems normal. So, this person's blood pressure at home seems normal. So, what are we going to do at this point of time? No diagnosis of hypertension. Continue periodic monitoring? Yes. So this is your learning number one. So step number one is blood pressure at home is more valuable than office-based blood pressure. That is number one. Number two, hypertension is defined as blood pressure more than 130 over 80, but it must be confirmed. Okay, so that is your learning number two. If out of office blood pressure is normal, usually we identify the patient as if they are having white coat hypertension. White coat hypertension. So in this case, are we going to diagnose this person with hypertension? No. We are only going to continue periodic monitoring. Okay. So everyone, this is how I teach. I like teaching embedded into the questions rather than just starting with something and saying that, okay, according to the new guidelines, blood pressure is less than 130 over 80 is now normal. Okay. And then home blood pressure is more meaningful than office. Okay. Third point that I'm going to say over here is that if home is normal, office is not, then it is white coat. I don't do that. Okay. I like it mixed. Do you guys like it mixed with the question? Yes, no, yes, no? Yes. You know why? Because you retain more. Okay. You retain more information that way because you have an example right in front of you. You did a question, right? You did a question in front of the 33 people that are here. Okay. So if you got it wrong, then you know you got it wrong, right? If you got it wrong, then you know you got it wrong. Correct? So that's the most important learning from here. Okay. So Dr. Frank and everyone else, make sure that you remember some of these things. Good. Let's do next one. All right, 68-year-old woman with type 2 diabetes has blood pressure readings averaging 134 over 82 on repeated office measurements. His home blood pressure is 136 over 82, right? So blood pressure is high, correct? Blood pressure is high. So let's see, what did you guys say? So let's see. Samuela said just do lifestyle modification, tell them to cut down salt, maybe lose some weight. Take some Ozempic, right? Take some Ozempic, lose some weight. No. So lifestyle modification, do exercise and stuff, right? Dr. iPhone says maybe start on ACE inhibitor because blood pressure is high. I'm worried about it. Good. Everyone else, Javaria and everyone else say, yeah, you know what? Cut down on some lifestyle modifications, make some changes. Okay? Do not eat chicken tikka masala every day. Okay? Do not eat a pizza or poutine every day. All right. Cut down your naan. Okay. Just have only plain roti with no salt. Right. So you're going to do that. Lifestyle modification. Good. What else? So majority of you guys want lifestyle modifications. Some of you have said we will start with single agent ACE inhibitor. Okay. Great choices. Well, those are all old guidelines. Okay. What does new guidelines say? So new guidelines says that anytime a patient presents with hypertension, it is likely that they have high BP most of the time, right? Most of the time. Sometimes it is even higher, okay? So too much harm, okay? Too much harm. For that, the recent guidelines, you know what they say? No, don't start with single agent. They say start with two agents. If you diagnose anybody with high blood pressure, you start with a combination therapy. You start with a combination therapy. So previously, we used to say, you know what? Cut down your salt, cut down the butter chicken. Don't worry about it. No. Now, we start with a combination therapy. ACE inhibitor plus thiazide or a calcium channel blocker. Calcium channel blocker. Okay. All right. In this particular case, why do we start with combination therapy compared to lifestyle modification or anything else? Because again, this is your QE1 basics. You start taking a look at the risk factors for the patient, right? So, more than 65-year-old, check. Postmenopausal female, check. Type 2 diabetes, check. Are these like risk factors for cardiovascular disease or stroke and stuff like that? Are these risk factors for that, everyone? Yes, no, yes, no? Yes, they are risk factors. So if a person is high risk, do we need to start intervening more? Do we need to start intervening early? Everyone? Yes, no, yes, no? Yes, absolutely. Absolutely correct. Okay, so we have a question over here. Dr. Reena says, if it is the same patient but no risk factor, then what do we do? Very good question, Dr. Reena. You know what? I am going to share the link to the hypertension guidelines. Why don't you read it? Why don't you find it and then paste it in my group on Telegram and we can all have a discussion on it. I will paste the details over here in 2 seconds. Give me a second. All right. All right, let's take a look. What are you guys saying? Okay, you're still reading? Okay, no worries. Okay, so 60-year-old man is started on ACE inhibitor plus thiazide for hypertension. His blood pressure after 3 months is 134/84. He feels really well. What is the best next step in this case? So what are you guys saying? A, continue the same therapy. A, continue the same therapy. Anyone else? How many do we have? 35 people we have here today. And how many have answered? One, two, three, four, five, six, seven, eight, nine. Oh my God, only 9 people answered? Come on, man. Everyone else? Come on, Dr. Emmy. Who else? DP, Frank, all the iPhones, Dr. iPhones that have joined. I only have one iPhone who answered. Right? Larnie answered. Probably she did. Marlene, Marianne, two Mariannes, Pedro, good, good, very good. Winona, good. Okay, all right, amazing. All right, so what are we gonna do? So again, everyone, so let me tell you this. So majority of our guidelines, right? Majority of our guidelines are moving towards preventing complications of a disease, preventing harms of a disease, right? So let me ask you this. Is this blood pressure 134/84 normal? Everyone? Yes, no, yes, no? Is it normal? No, it is not normal. Then why are you guys telling continue the same therapy? If the blood pressure is not normal, it's high, then why are you telling me to continue the same therapy? Would you not do anything about it? It is high. Then why did everybody choose A? Right? You guys know it's high. Then why did you choose A? A is the wrong answer. Okay, this is not correct. It's wrong answer. So, what do current guidelines say? If two agents are not controlling it, right? If two agents are not controlling it, what do? We add a third agent. Okay, we add a third agent. Now, why are they telling us this? Why are they saying that? Why are they saying that start with two agents, then add a third agent? Rather than that, you know how we used to do it before? We used to start with one agent. Then we used to increase the dose to max. Then we used to add another agent. Then increase the dose to max. Everyone remembers this? This was the old approach we used to do. Yes, no, yes, no? Yes, right? So, Dr. Samuela, patient feeling better or not better has nothing to do with it, right? A patient with hemoglobin A1C of 9, even if they feel better, doesn't really mean much, okay? If their A1C is 9, we have to control it, right? Same goes with hypertension as well, correct? Okay. So this was the old guidelines we used to use, where we were starting with one agent, increasing the dose to max, and then adding another agent. Well, now they have found that if you have two anti-hypertensive agents, right? At low doses, they do better control of blood pressure with minimal side effects compared to one high dose agent. And same goes with adding the third agent. So if you have, let's say, 3, 4 medications at the lowest dose, it makes a very big difference in blood pressure or diabetes or whatever it is compared to adding just one medication at its highest dose. And if you guys don't know about this, there is a study that was published on statins, right? So let's say atorvastatin, for example. Atorvastatin is used for lowering cholesterol. Correct, everyone? Lowering cholesterol? Yes, no, yes, no? Yes, right? So atorvastatin is used for lowering cholesterol. And it has various doses like 10 mg, 20 mg, 40 mg, 80 mg, and so forth. It has various dosings available. So the difference in the efficacy from 40 milligrams to 80 milligrams is not a lot, hey? Is not a lot. Okay? So that's why, like, let's say if someone is on atorvastatin 40 plus you add ezetimibe 10 or 20, that has a lot more efficacy or power in reducing cholesterol than just going up to atorvastatin 80, right? Also, side effects can be managed very well at lower doses as well. Does that make sense, everyone? Yes, no, yes, no? Perfect. Okay. So this is the concept that we are using in a lot of guidelines. Let's say whether it is cholesterol guidelines, hypertension guidelines, and so forth. Good. So third agent. Okay. Next. All right, 74-year-old man with hypertension on ARB plus thiazide plus amlodipine is at maximal doses. Blood pressure remains still at 138 over 86. What is the most important next step to do? So you guys are correct. According to the new guidelines, the fourth agent that we add is spironolactone, right? The fourth agent that we add is spironolactone. Apart from this, do we do anything else? Apart from this, do we do anything else? So we add spironolactone. What else can we do in this case? What else can we do, everyone? Come on. What else can we do? Fast, 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 fast. Tick, tick one, tick, tick two. Refer, no. Wrong answer. Anything else? Tick, tick one, tick, tick two. Come on. Four agents. Okay, very good. All right, Dr. Rachana, done. You'll pass your MCCQ even. Good. And what we can do is, if their blood pressure is still not controlled on 3 to 4 medication, you look for secondary causes of hypertension. What are some of the secondary causes of hypertension, everyone? All of you smart people, tell me secondary causes of hypertension. Renal artery stenosis. Okay, let me write it one by one. Renal artery stenosis. What else? Which is probably low down the pipeline. But anyway. Pheochromocytoma? No. That's for USMLE. Primary aldosteronism? No. That's for USMLE as well. So let me do it. One, two, renal artery stenosis, okay. 3, 4, 5. Con syndrome, you guys said. What else did you say? Pheochromocytoma. Come on, like easy stuff. Okay. Can hyperthyroidism cause high blood pressure, everyone? Can hyperthyroidism cause hypertension? Oh my God. Is that like common compared to like Conn syndrome and Cushing syndrome and stuff? Yes, absolutely. Can obstructive sleep apnea cause, Dr. Carla said it, can obstructive sleep apnea cause hypertension? Oh my God, yes. Is that very common compared to pheochromocytoma? Yeah, see, this is what happens when you read USMLE. Hyperthyroidism, right? Obstructive sleep apnea, right? And there are multiple causes, Graves' disease and this disease and that disease and all of that can cause it, right? Are there any medications that can cause hypertension? Everyone? Yes, no, yes, no? Yes, the American. Oh my God, oral contraceptive pills, NSAIDs. Oof. Do we use like Advil and Aleve and stuff like that, ibuprofen and stuff a lot? Yes, we do. Are there steroids? Oh my God, we use steroids everywhere too. So can medication induce hypertension be there? Oof. Yes. Oh my gosh. Then why do you guys say pheochromocytoma, Conn syndrome, Cushing's disease? You know why? Because your brain is programmed like that, right? Because we think how books write, we go like that. We don't go with very common causes that is normally seen, right? That is normally seen in our office, hospitals, and emergencies. Ah, nice. I like it. Horses before zebras. There you go. I love it. See? Horses before zebras. Yes, that's it. Right? So you gotta go with common things, right? You gotta go with common things. Good? All right. Nice. Moving on. So this was spironolactone is the answer. Okay? All right. Now, let's take a look at some of the theoretical parts before we end our session, right? So, what is the single biggest change in this guideline? What is the single biggest change in this guideline is hypertension is blood pressure more than 130 or 80 and combination therapy is now first line. Okay? Combination therapy is now first line. Okay, not like the previous ones. Old approach I have written and the new approach as well. So old approach hypertension more than 140, 90. Now we have 130 or 80, right? We had different targets depending on what was going on. Now we usually have a single target, right? And in old approach, we used to start with monotherapy, correct? Now we start with a combination therapy. Okay, now we start with a combination therapy. Big difference between the two. All right, let's go through some more theory. So hypertension is blood pressure more than 130 or 80. What else? We need to measure it with a validated device in a proper technique. So majority of the devices that you find, right, like you get it into a pharmacy, you get it from Costco, most of them are validated and proper. Technique, there is a whole slide on techniques and stuff like that. You can read it in the guideline that I pasted over here, right? The patient needs to be seated and it needs to be like at a instrument needs to be like at heart level and it needs to be like a non-dominant arm. All that stuff, you can read it. Less, it's not as high yield, so you can read it on your own. Why have we lowered the threshold from 140/90 to 130/80? Because evidence shows that the cardiovascular risk increases starting at 130/80. Okay. What will this happen? More patients will be diagnosed earlier and treated sooner. Okay. More patients diagnosed earlier and treated sooner. Good. And important thing, single office reading diagnosis should not rely on that. Okay, single office should not rely. So how should we measure it? Usually home blood pressure is the best one. If you do in office, then there are multiple ways to do it, but we usually do an average of 3 readings and so forth. However, home blood pressure is the best way to do it. Good. When do we start a medication? Right? When do we start a medication? So if blood pressure is 140 over 90, that's the one, or 130, 80, 130, 139 with high cardiovascular risk, right? 130, 139 with high cardiovascular risk. So what is what are high risk conditions, right? What are high risk conditions? So anybody, let's say, who has had a heart attack, atrial fibrillation, myocardial infarction, valvular hypertrophy, anyone who has had a cardiovascular disease, diabetes, CKD, age more than 75 is high risk, and Framingham risk score of more than 20. Okay, Framingham risk score of more than 20. Good. Then we start combination therapy, blood pressure more than 130. Okay, we start combination therapy, blood pressure more than 130. First line drug strategy. So as I told you, this is a major change. So we start with combination therapy, low dose, right? Both low doses we start. Usually, what do we pick? Usually we pick ACE inhibitor, okay, plus a thiazide or a thiazide type diuretic, right? So for example, we know like perindopril is an ACE inhibitor, okay, and there is a good combination of perindopril indapamide, right? There's a good combination of perindopril indapamide, and you can get a single pill of it, okay. Brand name is Coversil Plus, but there's tons of generics available nowadays, so you can get a combination of perindopril indapamide. There is also combination of perindopril amlodipine, right? Also a combination of perindopril, amlodipine. So these medications do exist, and if it is a single pill, then patients will benefit significantly from it. Okay. Third is your calcium channel blocker like amlodipine, right? And then after that, you add spironolactone, right? After that, you add spironolactone. So I have like listed it over here. Step one, start with ACE R plus thiazide. Step two, full dose, like increase the dose. Step three, calcium channel blocker, right? Now, let's say someone is taking R plus thiazide and their blood pressure is still high. You don't wait and say, okay, you know what? Let me go for full dose and then see, right? If their blood pressure, let's say they have diabetes and their blood pressure is like 144, 142 over 90 and stuff, with ACE and ACE R or thiazide, you add calcium channel blocker, right? Because you know that it won't come down as much. So you add the third agent and you see how things are. Fourth, spironolactone, and then evaluate for secondary causes. Okay. Fourth, spironolactone, and you evaluate for secondary causes. Everything clear so far, everyone? Yes, no, yes, no? All right. Yes. Okay, everyone. That's about it.